Hello, my name is Andrea Nolan, and I am a D&P student at Maryville University in St. Louis. This is my capstone project. It's called Examining the Impact of Video Monitoring. And first, I'd like to thank my D&P chair, Dr. Rita Wunderlich, and also my second reader, Dr. Lisa Stewart. Some background about my project. It took place on a brain injury unit within a rehabilitation hospital in the eastern region of the United States. And we found that there was an increase in falls with injuries. Staffing and budgets were strained due to the COVID-19 pandemic, increasing the number of staff needed in its workforce. A strong dilemma surfaced about the sitters not wanting to be in a COVID isolation room in full isolation mask, shield, and gown for 12-hour shifts. A solution, depending on some exclusion criteria, could be telesitters. Some definitions of terms that will be used in this presentation are as follows. Restraint. Any manual method, physical or mechanical device, material, or equipment that immobilizes or reduces the ability of a patient to move his or her arms, legs, body, or head freely. Video monitoring. A system that allows for patients at risk for falling to be monitored from a remote location. The monitor technician can speak to the patient directly and/or contact staff members to respond to the room preventing a fall. Telesitters. A telesitter observes patients at risk of harm to themselves or others using continuous video monitoring technology. This class of clinical monitoring technology can allow one virtual sitter to monitor many patients and patient rooms safely and remotely from one centralized location. Additionally, it provides the virtual sitter with many intervention and escalation paths that can be used to help prevent falls and promote patient safety. Falls with injury. 1 out of 5 falls does cause a serious injury such as a broken bone or a head injury. These injuries can make it hard for a person to get around, do everyday activities, or live on their own. This quality improvement project aimed to identify having a video monitoring system on a brain injury unit that would decrease falls with injury, restraint use, and use of one-to-one sitters at patients' bedsides. Centralizing resources would save funds that could be redirected into budgets for personal protective equipment, pay for more staff, more monitoring devices, and added safety devices. Computer tablets on stands in the rooms would monitor multiple patients at a time by one sitter from a central location. The sitter would have the capability to talk to the patient and call the nurse or tech assigned to go to the room to assist as needed. Anybody remember these? This is a library. The literature and evidence that is relevant and supports this quality improvement project searched for answers regarding the PICO research question. In adult patients on the brain injury unit, which is the population, does the use of video monitoring, my intervention, compared to no use of video monitoring, comparison and control, decrease falls with injuries, restraint use, and use of one-to-one sitters at the bedside? The databases demonstrate the high cost of falls with injuries and the mental stress of staff fighting altruism and their personal safety. The literature also demonstrated several suggestions in their outcomes to improve patient safety from falls. The search parameters were journals between 2011 and 2021 to capture the last 10 years of video monitoring with evolving technology, full text and peer-reviewed, and the Boolean phrases, some of them that were used: impulsivity, brain injury, falls, reducing falls, restraints, video monitors, and sitters. The criteria were narrowed further to be in English. The support for the adaptation of a video monitoring program is reliant upon the success of the literature review. Evidence that video monitoring was able to resolve the conflicts was compared in similar studies. The project's organization was most influenced by Kurt Lewin's three-step model. The leadership's style during the height of this technological intervention was to involve employees in expressing what they needed to change. Lewin's first observation is called the unfreezing stage. The nurses were more accepting of the emphasis on evidence-based practice, which made sure that the highest quality care was given to everyone. Critical thinking was being utilized and stood accountable to the outcomes. Training on how to use the workstation computer to communicate with the bedside tablets and how to chart required many hours of one-to-one training. Leadership needed the staff to be unfrozen and help to develop this program as quickly as possible. They encouraged input from all interdisciplinary teams, like physical therapy, occupational therapy, and recreational therapy. The employees got involved and were helping their colleagues understand how to navigate around the new computer program, which was developed to interact by speaking and seeing the patients. They helped develop a script for everyone to use to correctly redirect patients when possible. Knowledge sharing was the next step, encouraging everyone to ask questions and learn how to effectively use the software and keep the patients safe. This was the next stage of the change process. Again, leadership had to step up and be convinced themselves that this was the right program to have. Lewin's model showed that after this, implementation of the change will occur, and the organization will go through another refreezing as they struggle to accept the new normal of monitoring their patients successfully. Research is informed of the intricacies of gaining knowledge based on measuring values, logic, reality, and purposes because of one's methodology in conducting studies. The methodology chosen for this project was a quantitative exploratory design from data extracted retrospectively in a chart review. 2 months of data, pre and post intervention, to evaluate the effect on the rate of falls with injury, restraint use, and the use of one-to-one sitters at the bedside were collected. A convenient sample was obtained utilizing the inclusion and exclusion criteria. So for the inclusion, we had participants that were 18 years or older, that the electronic medical record had documented that they had a diagnosis of traumatic brain injury, and that they had scored a 45 or higher on the Morse-Fall score, which indicated that they were high risk. We also wanted to know that the patient was able to be redirected. The exclusion criteria consisted of the patient was less than 18 years old, or if there was no documentation about their Morse-Fall score. If the patient was not directable and confused to the point of non-compliance, they were not included in this study. Just like music and telemetry strips, statistics is a language that people learn to speak to describe phenomena. Quantitative research uses descriptive statistics to provide insight about the findings for data description and synthesis of information. This study utilized descriptive statistics to analyze the patient's occurrence data in an organized and systematic manner. This enabled the researcher to present the pros and the cons of implementing a video monitoring program to the other entities in a format that would accomplish the research task. Quantitative methods. 154 traumatic brain injury patients were selected randomly who fit the criteria to qualify for the research project. Subjects, 18 years or older, were extracted from retrospective electronic medical records and analyzed for their similarities in rates of pre and post video monitoring intervention. Randomization fit the study's purpose in utilizing the data to generalize findings to other populations of patients. Those subjects that were inpatient clients before implementation of the VM program belonged to the sample size. There were 77 of them. The subjects that were inpatient clients after the implementation of the VM program and a year later belonged to the sample size that was the second 77 group. The author used Excel spreadsheets and applied nominal data to the characteristics of whether the patient fell during that month. 0 equaled yes, 1 equaled no. And did they have orders for restraints? Was a physical person used as a sitter at the bedside? And was the patient able to be redirected and compliant with being told to get back into bed? The post data contained nominal data on if the patient was ordered a VM monitor or not. For this study, the lower tail z-tests for the difference of two proportions was used to demonstrate the significance of the differences for pre- and post-implementation of video monitoring. The z-value for fall rates was negative 1.96 with a confidence interval of 95%. The z-value for restraint use was negative 0.77 with a confidence interval of 95%. And the z-value for one-to-one sitters was negative 1.35 with a confidence interval of 95%. These values all suggested a negative change in ratio from pre to post intervention. Unfortunately, we did not achieve a strong enough power in this project, but the data, as you see, did demonstrate a small decrease in each category. So even though statistically it was not significant enough to justify changing a policy yet, this table shows that the patient falls decreased from 10 to 7 during the time parameter, 68 to 59 during the restraint orders, and 21 to 14 one-to-one sitters. This study had generalizability in that the data collection methods and the outcomes are useful for informing a clinical decision. A limitation identified was that the information was restricted to what was documented in the EMS records. The sample size that was determined by the G-Power software to be large enough to provide adequate statistical power was not sufficient enough to represent a great change in the outcomes of the rates of falls, numbers of restraints, and one-to-one sitter usage. This study also occurred during the COVID-19 pandemic, and that caused decreases in admissions, staffing, and educational support. This DMP project aimed at reducing the injuries and the burden of care for patients with brain injuries and improve workflow and morale. While this capstone project established that there was no dramatic change in the protection of patients and usage of restraints and added staff, it did boost the involvement and creativity of the staff who acknowledged that they felt that active involvement and change was done on theirs and their patients' behalf for the sake of improved quality of care. This study had no bias, being that it objectively gathered the data from the EMS and did not discuss the implementations before or after with the patients. VM technology provides real-time, insightful viewing of the patients during their normal activities so that patterns can be ascertained. The VM technicians then can be trained to foresee and plan for any impending fall events and intervene. Future research opportunities encircle staff attitude and buy-in of the new education needed for the updated protocols. The outcomes of this study reflected directly on the staffing needs of nursing at this hospital. New hospital policies and educational opportunities will be geared to fast assessment and documentation of high-risk patients, as well as good communication with the healthcare providers for early interventions. Closer attention to the current clinical practice guidelines and mobility assessments correlate to falls and can bring more insight in how a VM program would benefit our patients. In conclusion, Having access to a visual and interactive connection with patients who are high risk for falls with injuries offers safeguards and less invasive, cost-effective strategies for today's workforce. Sitters can now monitor several patients simultaneously. They can communicate and redirect patients via an intercom and ask them to wait for assistance, call don't fall, notify staff to respond appropriately to specific needs that are promptly addressed. So-called good catches have increased, and therefore interventions can be made faster and geared more specifically to the care requested. This is good for customer service. This is also great for providing safe environments for people's recovery. The process of this project had a huge impact on my priorities for safety and preventable harms. I believe that technology and medicine are joining together well to provide us the leverage that we need in times when the workforce is strained and the patients are more acutely ill. As you can see, I have a special dedication for all that has been involved in these last few years with not only my education, but my project, because it was born from a need that I said was part of what my colleagues were going through, and I wanted to help them. So in my acknowledgments, I start off by, my faith in God Almighty brought me this far. It is His calling to serve why I made it through the storms. I would like to express my special thanks to my project chair, Dr. Rita Wunderlich. She provides, not provided, provides invaluable guidance, comments, and suggestions, and she serves as an amazing mentor. She truly embodies the persona for the love of nursing and the love of teaching. She is so patient, so compassionate, and so effervescent that her love of nursing has made me strive to overcome all obstacles and finish these degrees and keep going. I also acknowledge and am eternally thankful for the numerous sacrifices and hardships that my husband had to go through as I had to focus and work to attain this goal of getting my DNP and FNP. I am extremely grateful to my parents for their love, their constant prayers, their caring, their sacrifices for educating and preparing me for my future. My sisters and my supportive family and friends all kept me strong by encouraging me and cheering me all along the way. So therefore, I dedicate this project, finally, to my magnificent Father for His steadfast assuredness that no matter what dreams I see ahead, that with God, I can do all things. So live your dreams and just work hard. You can make it too. I thank Maryville University for all the opportunities that they have given to me and all of the future endeavors I will have with their nursing program. If anyone needs to reach me, I can be reached by email at yourhealthadvocate@yahoo.com. It's spelt the way you would text it. So it's U as an umbrella, R as in rabbit, the word health, Health, the word advocate, Advocate, @yahoo.com. So it's yourhealthadvocate@yahoo.com. I hope that you have learned well from my presentation. I hope that you have gotten some ideas for your own programs back at your own hospitals. And I look forward to discussing this and reviewing this with anyone who is interested, I do find that it was a very successful implementation in our rehabilitation hospital. And I look forward to serving many generations to come with the knowledge that we have learned. Thank you so much.